So good afternoon. Okay, so the first thing I want to tell everyone is my presentation for today is already uploaded to www.slideshare.net/receptor if you want a copy. So I've entitled my presentation, Timely Insulin and Incretin Mimetics Treatment Strategies. This was a presentation I gave at the last convention of the Philippine Society of Endocrinology, Diabetes, and Metabolism. These are my relevant disclosure information. So let's start with a case. So this is the case of Linda, a 38-year-old female who has had type 2 diabetes for the past 5 years. Her height is 5 feet 3 inches. She weighs 160 pounds. Therefore, she has an increased BMI of 28.3. She is taking metformin 1,000 milligrams twice a day. Her hemoglobin A1C is uncontrolled at 8.8%. Her FDS is also not at goal at 148 milligrams per deciliter. Her mother had diabetes. She herself has 2 children and one weighed 9 pounds at birth. She's taking ramipril 5 milligrams for hypertension and simvastatin 40 milligrams for dyslipidemia. So the question arises, since her diabetes is not controlled, what oral agent or will you add insulin or other agents to manage her diabetes? So this is the guide that we have from the American Diabetes Association and the European Association for the Study of Diabetes, or EASD-ADA, that says that from metformin, which is monotherapy, we can go to dual therapy or even triple therapy. So all of the agents can be found on the slide, and basically depending on the risk factors or complications or of side effects and costs, we can basically pick anything, okay? So sulfonylureas and TZDs, for example, are associated with weight gain, as is basal insulin. DPP-4 inhibitors are weight neutral, and that is a consideration because our patient is already overweight. SGLT2 inhibitors and GLP-1 receptor agonists, on the other hand, can induce weight loss. For today, my task is to discuss insulin and incretin mimetics. So let's consider the issues at hand with adding insulin first, or should we add the incretin mimetic first, or in the end, even give a combination of incretin mimetic and insulin. So let's start with the rationale for giving insulin. Pancreatic beta cells can compensate in the long term for declining insulin sensitivity in the metabolic syndrome stage before breakdown after 10 to 12 years. So in the middle of the slide, you can see someone who's metabolically healthy but overweight. The beta cells are still able to compensate. Once the beta cells go into dysfunction, you will see impaired glucose tolerance. However, at the time of diagnosis of type 2 diabetes, we already have 50% loss of our pancreatic beta cell function, with almost 4 to 6% further loss of function expected every year thereafter. Furthermore, as you can see in this slide, there is a significant and progressive loss of beta cell mass. Actually cause beta cells to be destroyed, there is glucotoxicity and lipotoxicity. Both lead to a decline in beta cell mass and function. If we were to start insulin, that will actually correct the two defects. It will correct glucotoxicity. It will also correct lipotoxicity, improving peripheral insulin action and decreasing hepatic fat content. Now, if we were to do that, that would mean insulin therapy should be introduced, not as a last resort, as we often see, but as soon as metformin is inadequate to sustain glycemic targets. But what is the usual scenario? The usual scenario are because sulfonylureas are cheaper and they're very popular and we have decades of experience with their use, the common combination would be, for this case, adding a sulfonylurea or even a DPP-4 inhibitor, triple therapy, before adding insulin. Please remember that sulfonylureas stimulate insulin secretion in a glucose-independent manner, in contrast to incretins, and that is why we get hypoglycemia. They do not specifically target postprandial hyperglycemia, but rather fasting blood glucose. That's for sulfonylurea, and that's why they increase hypoglycemic risk. At least in vitro, there's also some evidence that they can increase apoptosis. On the other hand, basal insulin can lower, in a dose-dependent manner, our fasting blood sugar. Aside from the expense, what has been against insulin early on in the use is weight gain. However, this weight gain is balanced by improved insulin sensitivity, better plasma lipids, improved glycemic control, which can, on the overall, decrease our cardiovascular risk. So let me share this study with you, an analysis of early insulin glargine added to metformin with or without sulfonylurea and its impact on glycemic control and hypoglycemia. So there were a total of 2,171 adults with uncontrolled type 2 diabetes on oral agents given insulin glargine, and they looked at HbA1c reduction, percent achieving HbA1c less than 7, which is our goal, weight gain, and hypoglycemic events. So this was a pooled analysis, meta-analysis of 11 prospective RCTs. So what happened? After adding basal insulin, as you can see, metformin had a decrease of HbA1c of -2%, which was significant as compared to those who were only on sulfonylurea or those who were on metformin plus sulfonylurea. So there was a greater decrease in the metformin plus insulin group compared to the other treatment groups. Now, we know that it is effective, but we'd also like to see how many were actually controlled. So as you can see, 68% of the patients were controlled in the insulin plus metformin group. How about weight gain? So this slide shows the weight gain from each of the groups. And as you can see, because of metformin, it had the least amount of weight gain after adding basal insulin. So adding insulin glargine to metformin monotherapy early in the treatment may provide efficacy and safety benefits over regimens that include sulfonylurea. This may reflect treatment earlier in the disease and support the inclusion of insulin as a second step in the algorithm I showed you earlier. Another study on basal insulin and cardiovascular and other outcomes in dysglycemia is this one, the ORIGIN trial, which had 12,537 adults with severe risk factors plus pre-diabetes or type 2 diabetes. So they were already given insulin very early in the course of the disease to target a fasting blood glucose less than or equal to 95. And they looked at the following outcomes: non-fatal MI, non-fatal stroke, or death from cardiovascular causes. And this was a randomized controlled trial. So what happened? The ORIGIN study results gave some confusion to some because they were able to show that although the blood sugar was controlled with the use of the basal insulin, there was not much significant effect on reduction of cardiovascular events. So now they are saying, is this a study that supports or countermands the recommendation to give early insulin treatment? But what we can see from here is when we look at the data of hypoglycemia in ORIGIN versus ACCORD, for the HbA1c, you can see that the HbA1cs are comparable, 6.2% versus 6.4%. However, there was less hypoglycemia in ORIGIN at 1 per 100 person years versus 3.1% in the ACCORD. In the ACCORD study, people were put on up to triple therapy before they were put on insulin. So they were using the stepwise approach. The diabetes duration was also more for the ACCORD patients at 10 years with diabetes compared to the patients enrolled in ORIGIN, which was 5 years. So going back to our patient, will you actually start her on insulin based on the pathophysiologic explanation I gave on why insulin might work earlier in the disease for diabetes? How about instead giving her an incretin mimetic? Okay, so incretin mimetics mimic incretins like GLP-1, and they bind to GLP-1 receptors. Such GLP-1 receptor agonists include Exenatide, liraglutide, and Exenatide. And if you look at the algorithm, they are second tier as well after metformin. So incretin mimetics are injectables and they are relatively expensive. So locally, it is not a popular choice, a second-line therapy to start after metformin. So it's usually metformin plus or minus SU plus or minus DPP-4 inhibitor. Note that sulfonylurea cannot improve postprandial glucose by enhancing alpha cell function, which can be seen with the use of incretin mimetics. So how does the incretin mimetic work? So the slide shows the role of incretins in glucose homeostasis. So when we eat, you actually release gut hormones, and these are active GLP-1 and GIP. And usually because of the DPP-4 enzymes, these GLP-1 and GIP are rapidly inactivated. But we have these agents that actually prolong the action by hitting the DPP-4 enzyme. We have the DPP-4 inhibitors, and we also have actual GLP-1 mimetics. So as you can see, incretins act in a glucose-dependent manner to increase insulin secretion from beta cells. So they act as an insulin secretagogue, and it is more likely to have an optimal effect while beta cell function is preserved. There is also in vitro and animal studies to show that incretin mimetics can preserve beta cell mass and function, and hence potentially slow or halt disease progression. So glucose-dependent manner means that when the glucose actually goes down, the mechanism shuts off. And that is why, in contrast to sulfonylureas, you do not see hypoglycemia with these agents. So Dr. Ralph DeFronso already talked about the pathophysiologic approach to therapy in patients with newly diagnosed type 2 diabetes. It is his opinion that multiple drugs used in combination will be required to correct the multiple pathophysiological defects of diabetes. So treatment should be based upon reversal of known pathogenetic abnormalities and not on simply reducing HbA1c. So therapy must be started early to prevent slow progressive beta cell failure. So what is the most effective medication for diabetes? For Dr. Ralph DeFronso, it means to give an agent for each of the defects that cause hyperglycemia, as you can see here on the slide. But if you ask me, the most effective medication for diabetes is the one that the patient is taking. We know two ways by which the incretin effect can be prolonged pharmacologically. So GLP-1 receptor agonists resist degradation by the DPP-4 enzyme, while DPP-4 inhibitors inhibit the DPP-4 enzyme and extend the elimination half-life of GLP-1. So the question arises, are these two agents effective to the same degree? So GLP-1 receptor agonists, unlike DPP-4 inhibitors, exert digestive and food effects. GLP-1 receptor agonists act on the central nervous system, increasing satiety and therefore reducing nutrient intake. Inhibitory GLP-1 activity on gastric emptying further increases satiety and slows the entry of nutrients, including lipids, into the intestine. If we look at a review of monotherapy trials using either GLP-1 receptor agonists or DPP-4 inhibitors, we can see that the HbA1c level reduction is almost the same, 0.4 to 1.5% for the GLP-1 agonists and 0.4 to 0.9 for the DPP inhibitors. Both have low risk of hypoglycemia. However, there is more weight loss for the GLP-1 receptor agonist, as you can see, a weight loss of 2 to 4.3 kilos as compared to 0.2 to 0.9 for the DPP-4 inhibitor. So, how do we choose? GLP-1 receptor agonist or insulin? An article by Timothy Wright provides an excellent review of the head-to-head studies of Exenatide and liraglutide against sitagliptin. Okay. So here's the first study, safety and efficacy of once-a-week Exenatide compared with insulin glargine titrated to target in patients with type 2 diabetes over 84 weeks. So the Exenatide was given once a week for 84 weeks, and they looked at change in HbA1c and either glycemic parameters, incidence of hypoglycemia, and overall safety. It was a randomized, multicenter, open-label trial. So let us look at the level of A1C achieved. So the decrease in the A1C, -1 versus -1.2%. So as you can see, Exenatide, p-value of 0.029, seemed to do better, but only by about 0.2%. So as you can see, how many people achieved HbA1c less than 6.5. There was more with Exenatide, but for less than 7, it was not statistically significant. How about weight change? So if you see the graph, as you can see up there, insulin glargine, there was a weight gain of 2.4 kilos, and for Exenatide, a weight loss of 2.1. So that, I think, is the advantage. If the patients were on metformin alone before they added the Exenatide and the glargine, there was less hypoglycemia, as can be expected from Exenatide. Now, this is a comparison of Exenatide twice daily versus Premix insulin aspart 70/30 in patients already on metformin. As you can see here, it was given for 26 weeks, and they looked at HbA1c control and hypoglycemia. It was, again, an open-label randomized trial. So as far as HbA1c control was concerned, Exenatide was non-inferior to insulin, as you can see in our graph. There was, however, a lower risk of hypoglycemia with Exenatide, which is to be expected, 8% versus insulin, 20.5%. And also, again, the weight change. So they lost 4.1 kilos in the Exenatide group versus a gain of 1 kilo in the insulin group. So again, I ask you, going back to our patient, what will you choose for this patient, insulin or incretin mimetic? So if you can't make up your mind, maybe we should just give both. So we can actually combine incretin and insulin. So what do you want to do? Postprandial glucose can actually be addressed by giving short-acting mealtime insulins, but they carry a higher risk of hypoglycemia than basal insulin, and their use requires frequent injection and glucose monitoring. Short-acting insulin requires patients to eat to counter their insulin, which compromises weight management. So incretin, however, plus basal insulin can mimic the pharmacological benefits of basal bolus insulin therapy, but without the attendant calorie counting and the associated risk of hypoglycemia and weight gain. So there is a randomized control trial about the use of twice-daily Exenatide in basal insulin-treated patients with type 2 diabetes. So they were given Exenatide twice a day versus placebo for 6 months. And they looked at the change in HbA1c, proportion achieving HbA1c less than 7 or 6.5, body weight, and incidence of hypoglycemia. So let's look at the results. So for insulin glargine plus placebo, as you can see, the HbA1c did not go down as much as the group that was given insulin glargine plus Exenatide. So you can see that in the graph. Now, if you look at the proportion of patients achieving HbA1c less than 7 or less than 6.5%, which would be the goal HbA1c, more of them achieved this on the combination group of glargine plus Exenatide. Now, let's look at the weight gain. So as can be expected, the patients who were on insulin glargine plus Exenatide had weight loss, while those who were maintained only on glargine gained weight, as can be seen in this graph. Now, before we go overboard in combining these two, we also have to realize that it is unclear how the efficacy of incretin plus insulin will change longitudinally in the course of type 2 diabetes. Will there be desensitization? Will there be tachyphylaxis? Will there be immunogenicity that will limit the effectiveness of both treatments? For example, we know that there is an effect of incretins on alpha cells, and therefore an ongoing effect on alpha cell function would imply a useful role for incretins even in the late stage of type 2 or even in type 1 diabetes. So if we were to start someone on both insulin and GLP-1 receptor agonist, do we do it at the same time, or do we start with one first before the other? And the benefits of adding the incretin before the insulin or starting with the GLP-1 receptor agonist before the insulin is it may potentially delay or avert the need for insulin. It will lower the risk of hypoglycemia in comparison to just insulin therapy. The weight gain associated with insulin initiation might be minimized by established incretin therapy. And tolerance to nausea, which is a known adverse effect for GLP-1 receptor agonists, would have subsided before insulin is introduced. So this avoids the complexity of down-titrating the insulin. So I leave it up to you. What are we going to do to this patient? Are we going to give insulin, incretin mimetic, or insulin plus incretin mimetic? In the end, it is the patient's choice, and we have to explain the pros and cons